diagnosis, treatment and rehabilitation of people suffering from hearing loss and balance disorders. And also, as a clinical ear care specialist, I specialise in the removal of impacted earwax, infected debris and discharge from the ear canal. This client here attended with bilateral occluding earwax. So bilateral means both ears. Unilateral would mean from one side of one ear. The client has very narrow, twisty and hairy ear canals. The procedure here is of his right ear, and you can see that at the entrance there's a lot of cilia. So cilia is the term we give for hairs kind of in most parts of the body really. With regards to the ear, the cilia grow on the outer third of the ear canal. The outer third of the ear canal is made up of cartilage, and the inner 2/3 is literally a thin sheet of skin coating the bone. So the inner 2/3 is very, very sensitive if you do come in contact with it. The difficulty with this particular procedure is actually obtaining access into the ear. What I've had to do is insert the endoscope just beyond the entrance of his ear canal and then push it to the left hand side in this particular ear to stretch his ear canal open, because it was very narrow, almost collapsed at the entrance. That then provides me with the view that I require to remove the wax and allows additional space for me to insert the suction probe, and we're using the Zollner suction probe here. So what we're doing, we're just getting a suction grip. I'm wriggling this gently, loosening it from the canal wall, and as I'm loosening it and wriggling it, I'm also slowly bringing the endoscope forward, the suction probe, forwards, away from the eardrum, out of the ear canal. The wax is slightly dryish. You can tell by the colour, it's slightly dark as well, so it's been there for a fair while. The other challenging part of this case is once you've released the wax, is actually pulling it out of the ear canal. To extract the wax from the entrance, I've obviously had to remove the endoscope, so I'm no longer stretching the entrance open, and therefore I just have to put a bit of force, and you can see that here. I'm wriggling backwards and forwards, up and down, to really tug this large piece of wax through the narrow entrance. You may have seen on that piece of wax there's a few matted hairs. When you've got a narrow ear canal, this view actually gives you a good indication of how narrow it is. When you remove and extract a big piece of wax, the wax can often break into pieces as you're bringing it forwards, and you saw that there. That piece was actually from the previous larger piece of wax that I pulled through. You can see at the top there where I am is a bit of skin. With skin, you often get a white reflection from the torch. Obviously, skin is white. When you shine a torch on something that's a pale light colour, you do get a reflection back. And in the distance, you can see there's some dead keratin on the eardrum, but before that, there's some more wax. Keratin is another word for skin. I always like to, whenever I use a medical term, I always like to also then provide a kind of a more of a layman term, so the people who are viewing the video can relate to it. I'm sure many of you know many of these terms anyway. There's another big piece of wax, and similarly to earlier, as I brought that big piece of wax forwards, some of it got trapped at the entrance, and the wax separated from the bigger mass. So I'm just going back in to remove that. People often comment as to why I don't trim the hairs. The reason for that really is that although from a viewing perspective, so if you're watching it, I can understand that the hairs get a bit annoying. It's obscuring the view slightly, but in terms of me performing the procedure, it doesn't really impact me that much. I think there's only been about 2 or 3 cases where there's been so much hairs at the entrance where I've had no choice but to pluck them. And typically, as I've mentioned at the beginning of the video, the hairs generally grow on the outer third. So once you go beyond the outer third, the hairs no longer become as much of an issue. So a bit of wax, also some dead keratin attached then. I'm just going in with the endoscope again. I'm just stretching the ear open, inserting the Zollner suction probe in. Majority of the wax is now cleared. This particular ear, the right ear, was the easier out of the two. The left ear, and you'll see that in a moment, was a lot more complex, a lot more trickier. The ear canal itself was a lot more narrower at the entrance, but also very twisty, and you will see that a bit later on in this video. I'm now using a fine end gauge. A fine end gauge is an extension to the Zollner suction probe. It's got a narrower diameter, therefore there's less suction power. However, and also it's quieter for the patient. Now that I've removed the majority of the wax, a standard Zollner suction probe can be quite noisy. And whenever we go deep in the ear, adjacent to the eardrum, we always try, where possible, it's not always possible, to use a fine end. It provides you with more precision, more finesse, and if you do come in contact with the ear canal or eardrum, it's not as traumatic. I think someone left a comment that I kept saying that it's less atraumatic, and yes, that actually contradicts. Less atraumatic means it's obviously more traumatic. So I've made a conscious effort there to correct myself when explaining that. Just a bit of debris at the bottom of the eardrum there, and you can see it's very clear. A bit of a coating of dead skin and wax just on the anterior canal wall. So the anterior canal means the front part of the ear canal. It's not really causing the client any issues. I'm not sure whether I'd have gone back in there to mop that up. We'll have a look in a minute. I don't think I did. So when we perform clinical ear care, we're not trying to remove every little speck of wax. It's not what our job is, our role is. Our role is to alleviate the patient of their symptoms. On a video which is magnified, it may look like a lot, but it's not, and it's coating the canal wall. A bit of wax on the canal wall is not going to do the client any harm. I will actually try next time to take an image of my own ear and show you, and I've got probably more wax in my ear compared to the gentleman's right ear after the procedure, and I don't have any issues whatsoever with earwax. We're now doing the left ear, and this ear, as I mentioned, it's a lot more narrower at the entrance. Tried to use a Zollner suction probe, couldn't really get a grip. The wax was slightly matted as well. Therefore, I'm now using an ear hook, and sometimes with the ear hook you may not get big chunks of wax out, so that's a great example. It's not a huge piece of wax, but what you can do sometimes with an ear hook is actually dissect through the hard wax, slicing it and cutting it into smaller pieces, and you can then go in with the Zollner suction probe to extract those smaller fragments of wax. It's almost like a hammer and chisel effect. With the ear hook, sometimes you can use it to kind of break up the wax into little pieces, making it easier to remove. And there's another small piece of wax. It wasn't a tremendous amount, but it did help afterwards when I used the Zollner suction probe. Again, just even getting access to the ear, it's very tricky in the patient's left ear. And that reflection, you may have seen that, have some comments on it, sometimes it's too bright. Well, when you've got the endoscope very close to the canal wall, you do get a reflection. It's a light reflex. You do also get that on a healthy eardrum. When you examine the ear and the eardrum is healthy, you get a light reflex. It's the reflection off the eardrum of the torch itself that we use to illuminate the ear. And this generally happens. You do get a bit of white reflection when you perform procedures in people who have a narrow, twisted ear canal. You can really see there, you probably saw I was trying to put a lot of force there, just really trying to detach this dead keratin from the base of the ear canal. So it's actually keratin there, not so much wax. And you can see in this ear, the wax is a lot more matted, and when it's matted, it's so much more difficult to get a suction grip. Sorry. So yeah, I'm just working away slowly, just trying to tug this away from the canal wall. You can see there's a lot of force being applied there. I'm just trying to, at the moment, release the wax from the roof of the ear canal. So I'm getting a suction grip at the top and pulling downwards, really pulling downwards, trying to release it. And when you've got wax like this, that's really impacted, very dry, loads of skin adhesions, that's matted, it's important you try and release the wax from the entire circumference of the ear canal itself. So you were seeing me before from the bottom. Here I am again. Previously, I was trying to detach it from the posterior canal wall, the back wall, then the roof, and also from the anterior wall. Just see how kind of embedded this wax is, and the strength of these skin adhesions. They really are tough skin adhesions here. Nonetheless, we are making some progress now. I've just released the bottom layer of keratin, which will help release the wax. I've identified a bit of loosening there, a bit of a weak point in the impaction wax. So I've just managed to vacuum a bit of that looser wax from the anterior canal wall. Just going back in with the ear hook, and when we insert the ear hook a bit deeper in the ear, we do have to be careful. We don't want to make contact with the canal wall. But you could see there was where I removed that weak point, that piece of wax, it created an opening for me to glide the ear hook anteriorly in behind that dead skin wax, just to release it and, well, as I said, dissect it. And now I'm going back in with the Zollner suction probe. I vacuumed a small piece at the entrance. And again, we're just really pulling at this, trying to detach it. These are quite typical cases. People, especially elderly people, they do kind of have narrow ear canals or collapsed ear canals. Over the years, the cartilage weakens at the entrance and it collapses upon itself. Also, a lot of elderly patients do have a lot of hair that grow in the ear, not also in the ear but on the outer pinna. So the pinna is a satellite dish itself. Similar to how when men age especially, we tend to develop a lot more hair being secreted and growing in our nasal passages as well. Again, I'm just really just working away at this. There's no shortcut really. There's another big piece of wax that I managed to remove. And again, there is a few cilia there. I know if you're watching this, you may think, oh, it's in the way, it's not giving me the perfect view, but performing the procedure, it's not really causing me any issues. Again, you can see some keratin there, and there's a bit of a reflection there as well, but both at the base of the ear canal, you can see it just there, and also some reflection from the keratin. So when you do shine a light at keratin, and also very dry wax can also reflect light back. You do get a bit of a reflection back, a bit of a glare. Again, it's not affecting me in any way. On the iClearScope, on the app that we have, there is an adjustment there where you can reduce the exposure, so that's the brightness level, but it wasn't really necessary for me to do that in this case. Sometimes with children, pediatric ears, which are very narrow, very kind of not very deep in depth, I do reduce the exposure a bit to reduce the glare, because it's a lot more common with children. Conversely, when you have patients with a very large ear canal, like a mastoid cavity, sometimes you need to increase the exposure, put more light in to be able to view it. Again, you can just see how thick that dead keratin is there, and I've managed to get a good suction grip, and I'm just pulling this out, and it's coming out in a big piece there. Keratin is generally more white in colour, and as it oxidizes, it turns into a more pale yellow, a brown, and eventually black colour. Just like the right ear, I'm just having a few difficulties bringing this wax out from the narrow ear canal entrance, but I did manage. And with the left ear, we actually used the Zollner suction probe to retract the ear wider. With the left ear, we insert the endoscope into the ear canal and push open the cartilage. And when you're doing the left ear, if you are right-handed, it's the opposite. We actually use the instrument itself to extract the ear. Like I'm doing here, I'm just lifting the cartilage up, inserting the endoscope into the ear, which widens the ear canal and provides me with the view that I need, and it allows both instruments to be within the ear canal. So there's a slightly different technique adopted for the right and left ear of patients who have narrow ear canals and twisty ear canals. Again, I'm just stretching that open, and you can see now there's a bit of hair at the top there, but again, it's not really obscuring my view. I'm still able to remove the wax safely. If I were to remove the hairs, I don't trim them. We actually pluck them. We use crocodile forceps to do that. And now that I've got the outer, the more lateral layer of wax, so lateral means further away from the eardrum and nearer to the entrance, the wax is coming out a bit easier, and you can see there's a lot more skin adhesions there. And the patient also had skin adhesions very deep. So skin adhesions, dead keratin in his right ear medially, so close to the eardrum. With this piece of wax that I'm removing, there's a lot of loose hairs attached that are matted. And again, just at the entrance, so I've done kind of the difficult bit. I've extracted the wax from deeper within the ear canal, and then it's just a challenge wriggling this out. And you do have to put a bit of force sometimes there. Once again, I'm just stretching the ear open, inserting the endoscope, which provides me with the view that I require. And I'm just trying to loosen the wax from the anterior canal wall here. And as you can see there, I'm just gliding, and I try to avoid any contact with the ear canal itself, because that is the bony part. But I've managed to do that, and I've loosened this segment of wax, and now it's just a matter of wriggling it and tugging it out of the ear. You can see there's a few skin adhesions there. You can just see how narrow that is as well. It's virtually shut before I enter. So these cases can be a lot more challenging. So I'm now on the medial posterior canal wall. Client just found it slightly sensitive there. So as I said, this part of the ear canal is quite sensitive. We do have to be delicate, and you could see there was minimal contact there, but he did find it slightly uncomfortable. You're probably sure the camera kind of stutter a bit. And when we're performing these procedures, the patient is awake. There's no local anaesthetic, no general anaesthetic. We do adopt a brace technique. The brace allows us to combat any sudden movements, and it's not an easy thing to go through. I'm quite impressed by a lot of my clients, because you can just imagine a vacuum in your ear, which is already quite a noisy instrument, inside your ear, touching the wax, the canal wall potentially, just how still patients are. It's quite incredible. But there's a last bit of wax. We're using the fine end. You can see with this patient's left ear, the ear canal narrows. So this is the isthmus region. So the isthmus is about 5 millimeters away from the eardrum. And in most people, at this juncture, the ear canal narrows and then it protrudes back outwards again. And quite often wax can get lodged beyond this narrowing, and it's difficult to bring that lodged wax through this narrowing. So I'm just using a fine end gouge. Again, we're very deep, very medial. In this particular client, in the left ear, I didn't remove every little last speck of dead keratin or wax. As I said, it's not always necessary. And again, the patient just flinched there a bit, and we're making contact with the canal wall. So it just shows how delicate it can be, the procedure. So sometimes less is more. You can just see there a bit of so that was not actually the contact with the canal wall. He flinched there because there's a bit of keratin, and when I removed that, it caused a blistering effect. Imagine some dry skin on your finger and you peel it. It can be slightly uncomfortable, and you can see that's exposed just at the base on the right hand side. But the eardrum's visible. There's a bit of dead soft keratin there. It's not going to cause any issues. And at this stage, you also suffered from the caloric effect. When you vacuum the ear, you can actually experience a bit of vertigo. So vertigo is a sensation of the room spinning around. And that's because when we vacuum the ear, it reduces the ear temperature, and the organ of balance is located deep in the ear, in the inner ear. And we have two balance organs, obviously one in each ear. And when the temperature of each balance organ is different, it sends different mixed messages to the brain. So when we cool the ear, which is what vacuuming does, it inhibits the organ of balance. Conversely, if you raise the temperature in the ear, it excites the balance organ. And because we're not doing the procedure simultaneously in both ears, there is a temperature difference between the two ears, which then sends mixed messages to the brain. Your balance organ, one's inhibited, one's acting at a normal function, normal rate, and therefore your brain thinks you're moving because it's getting these messages from different messages from your ears, when in actual fact you're not. And that's when your eyes kick in, and your eyes try to correct your brain, to tell your brain that no, we're not moving, we are stationary here. And you do get vertigo, the eyes spin, and it can be sometimes quite violent effect, the caloric effect. And it does settle very quickly when we perform earwax removal, usually within a minute. And at this stage, if I felt it was enough, his symptoms have alleviated, and the patient was happy. I hope you enjoyed that video, guys. Sorry for talking a bit more. I'll post video. Just thought I'd like to be educational as well. People watch my videos for different reasons. I'm beginning to learn. Some people watch it for educational purposes. I do have a big fan base that are ear professionals themselves, so audiologists, hearing aid dispensers, clinical ear care specialists, nurses. Also some ENT specialists have messaged me kind of thanking me for my videos. Another fan base, people really watch it for entertainment, a bit like pimple popping. I'm sure it can be quite gruesome and satisfying to watch. But I've also discovered more recently a lot of people are watching the videos because they find it helps with their anxiety and stress, allows them to go sleep at night. And that's really interesting, and actually I feel quite privileged to know that. So it's always good to know your videos are appealing to many different people for many different reasons. Anyway, I'll kind of clock off now. It's late Friday evening, 7:45. I just wanted to upload a new video at the end of the week, just for the weekend. Hope you're all keeping well and have a lovely and blessed week.